this was a patient, this was a 70-year-old woman who was, pretty healthy, except she did have osteoporosis. And she was at her kid's house and she had not a ground level fall, but she fell down a couple stairs. And she had really severe back pain, very stoic, but her pain just lasted all day. So her kids put her in the car and took her to the ER. Now, the first two images that you see are x-rays. So I'm sure everybody here has seen an x-ray. So, a lateral view and a frontal view. Are you going to point? Do you have your pointer, Rasouli?
Yeah.
You point to those? Okay, thanks. So, whenever we get x-rays, when I see an x-ray come up on my list as a radiologist, my first thought for a trauma, for ER, my first thought is that ER doctor doesn't think anything's wrong with this person. If they really thought there was something bad, they would have gotten a CT. So I think that's how I know this lady was really stoic. She wasn't complaining. But they got the x-rays, and on the lateral view, you can see that, going down the spinal column, you've got normal vertebral bodies, normal, and then you see one that's flat. So that's her compression fracture, osteoporotic compression fracture. So, we read that, we called the ER doc, they immediately, took him to CT while they were making the other phone calls to work up this patient, which Rasouli's going to talk about in a second. But, the CAT scan is right there. It just takes a few seconds. So I'm going to tell you about the CAT scan, then you'll hear a little bit more about how they cared for this patient. So on a CAT scan, third picture over, you can again see normal vertebral bodies and then a flat one, and that's the compressed one. And importantly, you can see that the back of the vertebral body, the posterior superior aspect, is going back into the canal. Now, you all have had basic anatomy, so you know that there's no spinal cord down there, but there are nerve roots, and that is compressing the thecal sac, so it's important. Very bottom picture is an axial view, so you're looking from their feet toward their head. If they're laying on a table, you're seeing a perpendicular slice of their body, and you see a bone fragment going into the canal, which should normally be oval-shaped or round, and you can see that's causing some mass effect on the thecal sac and the nerve roots. Now, actually, if you want to go to the next one, you can either talk about management here, or we can talk about the MRI. What would you like to do?
Okay, let's talk about, so in terms of the initial workup, if a patient like this came into the emergency room, it's kind of rare that they start off with x-rays and get a CAT scan and get an MRI. Usually the first imaging test that a patient will get, if this patient was in acute trauma, is a CT. That's usually what you're dealing with. There's really no reason to get in terms of the clinical utility. If you have a CT, you don't really need to get an x-ray, okay? But the vice versa is not true. If you have an x-ray that shows something abnormal, you generally want to follow that up with a CT, okay? The only real utility of the x-ray is if this patient was standing and bearing weight when this x-ray was obtained. If they're laying supine on a table when this x-ray was obtained, it really does not provide any more information than the CT. Because many times, although things look abnormal or they look kind of bad on CT, you will be surprised how either good and or bad or possibly worse they look on a weight-bearing x-ray. So it's very important, in particular with trauma, at some point during that patient's hospitalization, that they need some sort of an upright or a standing x-ray of the area of pathology, okay? And that being said, before we get into the management and more of the workup and more where we can discuss the morphology of this type of this fracture, because when you're discussing this with your resident or your chief resident or your attending, you want to be able to talk about this intelligently. You don't want to be like, oh, there's a compression fracture at L4. That doesn't really, it means nothing to us. So we'll get into that a little bit. So let's talk about the MRI first.
Nothing to you. Okay, so for the MRI, this is something, this is pretty complex if you're a medical student, although I know that our friend Nader Dadale has talked to you before. He's given you some great spine lectures. I actually was there, I saw them. So I know he's talked about the different sequences that we look at. And so we won't go into too much detail on this, but just basically, you probably remember from what he said, the main sequences we have are T1 sagittal, which is the first picture. Then we have a T2. And then the third one is stir. And the only importance of that, I won't get into the physics of it, but that really highlights water. It either highlights edema within a bone in a fracture or infection or cancer. So the first one and the third one are probably the most useful in this case. So in the first picture, you see that the vertebral bodies all are bright. They're kind of the color of the fat in the back, the subcutaneous fat. And that's because bone marrow has fat. So if there's something else in the bone marrow, whether it's edema or cancer or infection, it turns black. So we can see that our fracture is black. That's how we know it's acute and not chronic. If she had had that for years and never got it treated somehow, it wouldn't be that color. So in this case, we know it's acute. The second picture over, we can see that it's going back, it's compressing those nerve roots. That's what we saw on CT, but here we can actually see the nerve roots, unlike CT or X-ray, so we can see what it's doing. And the third picture, again, it shows that there's edema in that vertebral body. It also shows us, importantly, that there are no other vertebral bodies involved. If this was higher up in the spine, it would also show us if there's any signal abnormality in the spinal cord itself, if there was a cord injury. And then the axial view on the bottom, that's also an axial T2. And it shows you, again, what that's doing to the thecal sac. Just on this, like on the CT, it should be an oval with the nerve roots kind of floating freely in there, but we can see that it's compressed by that bone fragment that's gone backwards into the canal.
The one thing I want to add is this positive SIR signal here shows the acuity. I think you may have mentioned this, but it shows the acuity of the fracture. So sometimes, going back to the previous slide, how do you know this is new, right? Sometimes, you see like chronic compression. This is obviously acute, but sometimes you see chronic compression fractures that can be really, really, really nasty looking. They can be like a vertebra plana. They can just look really bad, and you're not really exactly sure whether or not that's new versus old. So a STIR MRI, sagittal STIR, will let you know of the acuity of that fracture, so you can rule that out. So if you get this, you know immediately this is a relatively newer fracture. Now, that being said, frequently when you are communicating the results of imaging scans to your let's say we'll just use your chief resident in this case. You may be asked to send a video, or you may be asked to take a picture of the MRI and transmit it to them so they can see. You always want to err towards doing a midline sagittal T2 or a midline sagittal CT. These are the two scans that tell us the most information. So and then if there's STIR positivity, you want to give that as well too. These are the most important ones that we want to see right away.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.